Secondary amenorrhea, absence of the menstruation for greater than 3 months in women with the previous regular cycles or greater than 6 months in those with the irregular cycle. Etiology: hypothalamic causes like decreased GnRH secretion, functional hypothalamic amenorrhea, stress, excessive exercise, weight loss, and the Kalimann syndrome, GnRH deficiency with the anosmia. Pituitary causes like decreased FSH and LH secretion, hyperprolactinemia, prolactin hormone medications like the antipsychotics, Sheehan syndrome, pituitary infarction after the postpartum hemorrhage, pituitary tumors other than the prolactinoma. Ovarian causes like decreased estrogen, increased FSH and LH. Polycystic ovary syndrome (PCOS), increased androgen and irregular cycle. Premature ovarian insufficiency lesser than 40 years, autoimmune and the genetic. Turner syndrome 45 and Expo. Stick ovaries primary but may be present as a secondary. Uterine causes outflow tract disorders. Fisherman syndrome intrauterine adhesions often post DNC. Mullerian anomalies, uterine egenesis, and usually the primary amenorrhea. Endocrine causes hypothyroidism greater than TRH, greater than prolactin, and lesser than GnRH. Cushing syndrome excess cortisol suppresses the GnRH. Androgen excess. Catch androgen secreting tumors. Psychological, physiological causes like pregnancy, most common cause, menopause, and the lactation. Clinical features: history of the menstrual cycle, regularity, duration, and changes. Symptoms based on the underlying cause: galactorrhea, hyperprolactinemia, hirsutism and aching, PCOS and the androgen excess, hot flashes, vaginal dryness, premature ovarian failure, postpartum hemorrhage history, Sheehan syndrome, history of the uterine procedure, Escherman syndrome, rule out of the pregnancy beta-HCG test, hormonal tests like FSH and LH, high in the ovarian failure, low in the hypothalamic and the pituitary cause, prolactin, high in the hyperprolactinemia, TSH, hypothyroidism, testosterone, DH, PCOS and the androgen excess disorder. Progesterone challenge test, withdrawal bleeding, and ovulation PCOS. No withdrawal bleeding, estrogen deficiency of the outflow tract issue. Imaging, MRI brain, pituitary tumor if prolactin is high. Pelvic USG, PCOS and the ovarian failure, hysteroscopy, Escherman syndrome. Hypothalamic causes like lifestyle changes, weight gain, reductive stress. Hyperprolactinemia, gabapentin, chromocriptine, dopamine agonist, PCOS, OCP. Weight loss, metformin if insulin resistance is present. Premature ovarian insufficiency like HRT, estrogen plus progesterone. Escherman syndrome is a surgical adhesiolysis. Secondary amenorrhea, absence of menses after the greater than 3 months regular cycle or greater than 6 months irregular cycle. Most common causes of pregnancy always rule out the first. Hypothalamic causes include the stress, excessive exercise, and the weight loss. Hyperprolactinemia, prolactin hormone drugs inhibits the GnRH leading to the amenorrhea. PCOS is the common cause associated with the hirsutism and the irregular cycle. Premature ovarian failure presents with the high FSH and menopause-like symptoms. Escherman syndrome is caused by the intrauterine adhesion, often post-DNC. Progesterone challenge test helps differentiate the causes: withdrawal bleeding and ovulation, no bleeding, outflow defect, or the estrogen deficiency. MRI is needed if the prolactin levels are very high to check for the pituitary tumors. Treatment is based on the underlying cause: dopamine agonist for the prolactinoma, OCP for the PCOS, and the HRT for the ovarian failure.